Right, let's kick off. I can see that things are slowing down a little bit and perhaps some people continue to join us. But welcome. I'm Jenny Reindorf. I'm Interim Director of Funded Programmes at NHS Providers, and I'm really delighted to welcome you to the latest in our series of virtual events as part of our provider collaboration programme, which aims to share good practice and learning on provider collaboration hot topics through webinars like today and peer learning forums and case study briefings. It's great to see a diverse audience on the call. I know we've got exec and non-executives, provider clubs, programme directors and others. So welcome to you all. We do really appreciate you taking time out of your day when we know how busy everybody is. So the focus of the webinar today, we know that finding ways to build capacity is obviously really critical given the growing demand facing all of our services. So today we're going to hear from one provider collaborative, the Cheshire and Merseyside Acute and Specialist Trust Alliance, CMAST, about how they're doing this. And we're going to have a particular focus on diagnostic capacity, given its critical role it plays in recovering elective performance. So what we're going to do, we're going to start by handing over to Tracey Cole, who's Diagnostics Programme Director at CMAST. He's going to talk through some of the detail of the diagnostics programme that they've been leading at CMAST and doing some absolutely fantastic work, I can say, because I've had the heads up on the slide. So there's brilliant progress that they've been making across a really large number of trusts. That's very impressive. And then we're going to hear from Ben Vinter, the corporate lead at CMAST, on some of the key enablers that have helped them achieve impact and change, and a bit more of a chance there for you to kind of unpack some of the challenges they've faced and on what some of the enablers have been. And this is very much designed to be an interactive event, so do please feel free to post any comments or questions in the chat as we go, or any learning from your own work on building capacity and diagnostics capacity. After Tracey and Ben has spoken, I'll ask you to just pop your hand up or raise your virtual hand, and we can bring you in if you do have a question. Just as a flag, we will circulate copies of these slides in the post-event email, so don't feel like you have to scribble away. And this webinar is linked to a briefing that we're going to be publishing shortly on how provider clubs are building capacity. Initially, this is focusing on the Community Diagnostics Programme, so that will also share further detail on the case study that you're hearing about today. Okay, so without further ado, I'm just going to hand over to Tracey to kick us off. And thanks very much in advance, Tracey, for what you're going to say.
Hi, good afternoon, everyone. Thank you very much for inviting us to talk you through, I think, what we would regard as our journey so far. We have been moving towards a programme approach for diagnostics for the last 2 years and seen some positive results, but there's still a very long way to go, and we are still part of that learning journey. What I'm going to run through is how we've structured that, what's in scope, what we've focused on, some of the things that have been delivered, a couple of the challenges, and what we need to do in the next few years to keep the momentum going. And then, as you've heard, Ben will pick up in the second part around some of the things that are behind the scenes, non-visibles, that are really helping us to charge ahead. So on the next slide, I guess it just highlights why diagnostics was picked as a programme. There is pretty much nothing that can happen for a patient unless they have a diagnosis. Unless we know what's wrong, we can't put the treatment in place. And my favourite statistic is that 90% one, which comes from the Royal College of Pathologists, who state on their website that 90% of patient pathways require a diagnostic. So if we don't get that right, everything else is going to struggle, and it spans every part of the NHS and the care system. So that's why diagnostics and working together collaboratively in Cheshire Merseyside, we've put that focus on it and the ring around it. So next slide shows you the ultimate vision, which the top 2 blue bands are the ICB's vision, and I suppose the bottom one beneath that, the third one, is what's our role in delivering that vision, specifically for diagnostics. there is a range of good words at the bottom there, and none of them would you'd argue with. The problem is there's too much. Where on earth do we begin in delivering resilient, effective, efficient, and so forth services in diagnostics, which, if you stand back and look honestly, has developed organically across our system and most systems with the best intention, but not necessarily in a strategic and planned fashion as to how we can network and coordinate and deliver in a systematic way. And that's where we're trying to put that in place. On the next slide, we just wanted to start out and be clear on the scope. So we reset this programme 2 years ago, and some of that was about a change in SRO and the appointment of a programme director. But we wanted to be clear what was included, and effectively it's all diagnostics. Prior to that, there was a great focus on imaging networks and pathology networks, often because of the Carteret scale, model hospital, some of those other initiatives and policy changes. But what we said is we need to do all diagnostics because there are a lot of cross-cutting themes. Get one right, you can potentially impact on the other positively. We were also clear it covers all ages, so it wasn't just adults, and that all geography, even though we had some trusts that feed into different networks and different systems. The other word on there that just to draw your attention to is performance. When we started this, there was some tension, I think it's fair to say, as to whether performance was part of our role, or were we about transformation and performance would sit elsewhere. And one of the things I think we've established is that by delivering improved performance on a daily basis, that actually that then lends itself to moving forward towards the transformation agenda. So it is in scope, but that then is attention about business as usual and also how we transform for the future. But that's something that we're trying to grapple with. The next slide just shows you the 70 tests and how we group them. This is as much as anything to be clear what we are responsible for, where does it begin and end. But we've also made sure that some of the things that are not technically diagnostics are in there. So interventional radiology tends to be a homeless topic, but it's very important for cancer, urgent care, you name it. If we don't look after it, who will? Which programme does it fit in? And you'll also see PET CT scanning, again, not necessarily diagnostic in all cases, but very important that things have a home in a transformation programme at system level. On to the next slide, and it just shows you what we sort of stood back and said, why is this so hard? The complexity in Cheshire and Merseyside, and for many ICSs, is the number of providers, the number of policies, the number of digital systems that don't talk to each other, and pathways, and staff who can't necessarily work in different trusts and different settings. And what our job is to look at how we can do this once and do it well across that system, rather than the fragmented pockets which have grown organically over the past few years. So what we've done on the next slide shows you is group that into the diagnostic programme. So you can see the green box is the CMAST, the Cheshire Merseyside Acute and Specialist Trust Provider Collaborative. And I think a great deal of support comes from being under that umbrella. There's a real focus and a determination, and Ben will talk about that more. But what we needed to do firstly when we set this programme up was be very clear that we've got robust, clear, transparent governance. So that delivery board is chaired by our SRO, and then we've set up beneath that the networks that feed into it, and then you can see the cross-cutting themes. So I just now want to move on to what have we delivered. And as I said at the minute, the caveat is this ain't done yet, and we have a lot to learn, and we are constantly learning and stealing with pride from other systems and want to continue to do that. So I'm sharing with you our journey partway through, and I wouldn't say we've got it all sorted yet. It's just that we think that we're having some impact and that we want to see that continue. So I've split this into 5 sections just on those headers. So looking at what we've done in CDCs, what we've done in imaging, pathology, and so forth, so that you can see some of the initiatives that have helped this. But going back 2 years ago, our waiting times were way too long. We didn't have any diagnostic centres. There's that chronic underinvestment in diagnostics, and our services were working in silos and were fragmented. We've now, some of our words are slipping off the boxes there, but you can see what we're trying to say is by being in the right place at the right time, we've secured a great deal of capital investment for our system. We've driven up the amount of activity being delivered, and we've brought down the waiting times. And we've also now got 10 community diagnostic centres open within our patch that are contributing towards that increased capacity within the system. So if I just take bit by bit, I'll just show you another graph about what we've delivered, and then I'll take it section by section as to some of the initiatives. So the next slide just shows you our activity. These are DMO1 tests on the left, which is only 15 of those tests that I showed you the 70 earlier on that are currently measured and reviewed by NHS England. So the data is not ideal on diagnostics, and that's one of the things that we need to look at and are trying to rectify. But in terms of something that is measured and is part of the planning guidance, you can see that we are driving up the activity to deal with backlogs and increased referrals. And this is our 13-week waiting list on the right. You can see there's been an increase. That was Christmas and industrial action, which has heavily affected us in Cheshire and Merseyside. But I'm pleased to say it's starting to come down again. But you can cut that for 26-week waiters or 6-week waiters, you name it. All along, our job is to bring down those waiting times so that we support cancer targets and make sure that we are ahead of the game for all our patients. The next slide just talks about our community diagnostic centres. The one that you can see being built at the bottom sits in Northwich. It's been open for 2 years now, I think, off the top of my head. We're really proud of having 10 community diagnostic centres and that additional capacity that has created. I think what was one of the tickets to our ability to do this was to focus on modernising rather than new build, and also use sites that already had that CQC oversight from an existing provider. It was much harder to get things set up in a shopping centre or something that is not already a clinical setting. And so that's allowed us to mobilise quickly in line with the timescales. So whilst you can see an awful lot of bricks on the floor there, that was a build that was modernised rather than new build, and you can see that the drop in there of the scanner, etc. And that seems to have helped us to progress where we've reutilised existing capacity. In endoscopy, on the next slide, lots of words. I'm just going to, in each of these next slides, just pick out one area, but happy to help with anybody on things that we've done. You can see the words on the right, real-time productivity monitoring. So the first thing we've done in endoscopy is gain clinical agreement and implement a system that is in place in all our endoscopy units that allows us to monitor productivity. There's an agreement about how many patients should be on each list. We monitor that that's booked. We monitor late starts to clinic. We monitor DNA rates. We monitor the reason why endoscopy lists started late or run over. And it's all about those marginal gains in terms of efficiency and productivity. And I mean, there's a key stat in there around we've been able to target what was driving DNAs and reduce those so that we maximise existing capacity rather than then outsource where we don't need to if possible. The next slide talks about imaging. I think the one that I want to focus on here is around the AAT at the bottom of that slide. Many areas are doing this. And we've installed advanced acceleration technology on 19 MRI scanners, and also brought in the medical physicists to work across numerous sites that allows the machines to be maximised so that we can deliver at least 10% productivity. What that does is makes the machine run faster, so appointment times can be reduced, patients spend less time on the scanner, and again, we've seen a huge drop in the amount of funding that's being used in the independent sector because we're now using our own MRI capacity in an optimised way. On the next slide, we're going to look at pathology, and I think the thing that I'd like to just focus on there is right in the middle of the page on vitamin D guidelines. So there's a lot on there, but I think just to bring that one to your attention, I guess it's probably the easiest one to implement, because NICE has done the work by making clear who should have a vitamin D test or blood test ordered. They're quite expensive. Vitamin D tests, they're about 10 to 15 pounds per test. And we know that there are a high number of patients having a vitamin D blood test when actually they don't need it if you follow the NICE guidelines. So this hasn't been completed yet, but we're rolling that out. And the estimate from what we've looked at is that should reduce the number of tests by 50%. Key to that was GP engagement, because a lot of those are ordered by GPs. And that comes back to how we've got the clinical leadership involved in that. The next slide looks at physiological measurements. This is the least developed area of our programme, and we're establishing a physiological science network under the guidance of NHS England, and we hope to be one of the first ones in England to do that, which would then be a network of networks such as audiology, ophthalmology, and all the other 8 areas beneath that. The thing that we wanted to just draw your attention to is at the bottom of the page there is the mapping of diagnostic services in primary care and community. We think we're the only place that's started to try and address this. I've talked to you a lot about what we're doing, and it's all acute focused, but actually a lot of our tests, if you think about that 70 list of 70 tests, are delivered in primary care and community settings, but we don't have the data on them. We don't know where those tests are, and most systems won't, because they're commissioned by lots of different places and different areas. What we need to do is map them all, harness them, make sure that we've got the same digital connectivity and quality initiatives, again, so that we can roll out what we need. So there's some key guidance being delivered on having direct access to Spiro and Pheno testing for heart failure and COPD patients. So again, that will come under our programme to try and make sure that systems have got the access in place, and that won't necessarily be acute focus. We need to think about those other settings. So the last 2 slides from me is what next. We haven't finished this, and we've got such a long way to go. We will continue to focus on waiting times, we have to, and the productivity piece is really important. But you can have your test today or very quickly compared to how it was a few years ago. But you might be waiting a long time for the results to be reported on, either from pathology or radiology or other aspects. And so that part of the test journey is now a key focus, and we expect that to be in the planning guidance. So that's our next key focus. I haven't written in here patient involvement, but I think that's a cross-cutting theme. I think there's more that we will be doing, and we've had some conversations about understanding why our patients not attending for their endoscopy test, and what can we do to help people attend for their tests, so that we again run at maximum productivity. Digital is huge. How do we connect our services and that whole system oversight, so that we're not just looking at acute capacity and initiatives? How do we lock the whole system together to deliver ultrasound tests or whatever the test is in a way that looks at all settings? We've set in place some organisational development, particularly for our clinical leads, and also the one that should be right front centre is workforce. We can have as many machines as we want, but without the workforce coming through, we are always going to be limited. And last but not least on there is automation. There's a lot of processes that happen that don't need a human, and also we know that there's a lot of artificial intelligence in diagnostics that can help us increase our productivity, but also the quality of diagnosis and increased diagnostic ability. The last slide from me is just a podcast advert, if you will. There's 2 key people that you can see in that picture. On the left is Ash Bassi. He's one of our clinical leads for endoscopy, which has been critical in the success, is that clinical buy-in to what we're doing. And also Liz Bishop, who is our SRO. Liz has got many hats, one of which is Chief Executive of the Liverpool Heart and Chest Hospital and Clatterbridge Hospital, but she also leads our diagnostic programme. It's a friendly chat from them, but I think if you did want to know more, that's quite a nice listen on the way home from work. So Jenny, I will leave that there, and I hope that was a useful run through of some of the things that we're doing in Cheshire and Merseyside.
Fantastic, thank you so much, Tracey. And I think it's a really impressive kind of headlines there about how you've made the best of existing capacity as well as adding new capacity, and through that kind of mapping exercise, looking at DNAs. It's amazing kind of what you've achieved. I think particularly in the context, as Ben is going to elaborate in a minute, working across 13 trusts, so one of the largest provider collaboratives in the country. While you're thinking of questions that you might want to ask at this point before we move on to Ben, do just pop them in the chat, or do also just pop up your hand. One thing I was just going to ask Tracey is just that piece around clinical engagement. And you said there that you're planning to do some work, some OD work with your clinical leads. What's been some of the kind of secret of your success so far in kind of particularly thinking about the number of kind of pathways and number of organisations you're working across of getting that clinical engagement from the outset? And then I'll throw to Kamal after that.
Thanks, Jenny. So we're fortunate we have clinical leads for each of the networks. So rather than having a diagnostic clinical lead, you saw Ash, he's for endoscopy, and we have someone for pathology and someone for imaging. They're credible, and they know their stuff, and they are system thinking. So that's one of our kind of mantras. They are not about their organisation. They are there to do what's right for all patients in our system. And it's about relationships, isn't it? So they spend a lot of time working with their peers, trying to understand what they need and what would help them to do more and go faster and go further. So they have said that that isn't always without challenge, and they'd appreciate some leadership guidance with that, which is where that OD piece has come from. But I think some of it is about personalities, some of it is about being able to use the governance, and it's about building those trusted relationships, which I think anybody would answer that question that way if you asked about clinical leadership. And I think we are lucky with the work and the people that we have that are committed to what we're doing, but it isn't without challenge.
Yeah, I'm sure. Thanks, Tracey. That's really helpful. I'm going to bring in Kamal and then Ralph. And do feel free, if you can come off, on camera, if that's possible. Always great to see you where that's an option. Kamal.
Thank you. I'm just trying to switch my camera on, but it doesn't seem to be working. I'll just try that. Okay, I think it was working just now. Right, Kamal Balakrishnan, Head of Diagnostics Programme in Southwest London, Acute Provider Collaborative. Tracey, that's very impressive, the kind of work that you do in Cheshire and Merseyside. And I think we had the good fortune of speaking to Ash for our endoscopy summit when we had this in Southwest London. It'd be really helpful to kind of understand a few things that you mentioned about, very, very impressive about, say, pathology, where there was information about slides going, being sent worldwide to access a larger workforce. Workforce, we know, is a major challenge, not just in pathology, but endoscopy, echocardiography. And really keen to understand, how we could do this offline. I'm really keen to understand how you've managed to do all this across all those modalities, because it's exactly what we're trying to do as well in Southwest London. Sometimes you feel that you're swimming against the tide. You try and do so much, and you're still stuck there. But yeah, just kind of thoughts on that, and also the endoscopy. Again, impressive, reducing the DNA from 8 to 4%. RDNA plus cancellation. It's like a mixed bag, basically. I was struggling to separate DNA from cancellation. We are sitting around 8 to 10%. And endoscopy especially is a bit of a challenge because of the kind of tests on the cohort of patients who come in without appropriate prep and stuff. But just understanding how you drove that percentage down, which improves the productivity.
Thank you very much. Happy to answer them in reverse order, because I'll probably forget if I don't. In terms of the DNAs and the hospital cancellations, it's always the same. You need the data, otherwise you're having a go when you think you've got the cause, but you need the data. So the productivity tool that we've implemented has been absolutely critical, because we can then separate out hospital cancellations on the day, which are frequently due to patients not being prepped adequately, and true DNAs where patients don't turn up. And we've tended to find then you can track the root cause and the themes. So we noticed that Monday mornings for colonoscopy are particularly high in one trust. And some of that was linked to lifestyle choices about not wanting to take bowel prep over the weekend. So there were some discussions around how we handle that, and then how it always comes back to investing in booking staff to reduce DNA so that patients know what they need to do, they're well prepared, and also then understand what's going to happen and get the reassurance. So again, we do see it does fluctuate, but we certainly then, there was an initiative around then potentially not booking colonoscopies on a Monday morning and using those lists for other procedures, and weighting those more into the week. But that it varies by trust. So there isn't a one size fits all solution. It's a data analysis and working with the teams. Your first question was about, I think, workforce. Was that where you were going, Kamal?
Yeah, how you're swimming against the tide, I think, Kamal, was your wording.
So I haven't mentioned the endoscopy academies and the imaging academies, but we're working really closely with those initiatives. Overseas recruitment has been a big part, not necessarily in endoscopy, but in all aspects. We're also looking at a diagnostic bank so that staff can work between trusts. And I think, I have to be honest, I think it's an area where we've got a long way to go. And I think there's a lot that needs to be done around apprenticeships, and how we can make it easier for staff to stay conversations as well, so that we retain existing staff. So I don't think that's something that we've got cracked yet. I think it's definitely work in progress.
Thanks, Kamal. Thanks, Tracey. That's a great question. So Ralph, and then I'm going to bring in Daniel.
Thank you. So I'm Ralph Michelle, also from Southwest London. I'm Director of Strategy at St George's in Epsom St Helier. And I wondered if you could just say a bit more either about what you've done or are thinking of doing in the space of collaboration around reporting.
Great question. Thanks, Ralph.
Yeah, thank you. I'm not sure yet. It's huge, and I think we've got a long way to go. So we've done a deep dive on histopathology. So I guess that's the first aspect, and that's really critical for our faster diagnosis standard, looking at number of slides and blocks that are produced, and how we can then network that solution using digital pathology rather than an older set methodology. In terms of reporting, for imaging, we have a reporting collaborative that we've put in place so that trusts can cross cover for each other, and we're just working through the details of that. And again, I think that's something that we have more work to do to, again, you first need to understand your problem before you put in the solution. And so there's a lot more work to do around that, but the collaborative in imaging is in place. I think that's probably as much as I would say. Oh, the only other thing is the digital system. So we've got the business case ready for implementing a PAC system. We've got a single PAC system, and we want to implement that for cardiology as well, to stop that duplication. We know at the moment we've got patients who will have an echo in one site, go to another site, it's not visible, it gets repeated. So that's a reduction on the reporting as well as a reduction on the scanning time. So I think there's several strands to that. And that's definitely for next year where we need to major on it, Ralph.
Thanks, Ralph. And Daniel, just to bring you in.
Thank you, Jenny and Tracey. Excellent presentation, and very helpful in terms of us in Sussex, because absolutely diagnostics has to be the focus. For the stat you gave, 90% of patients have a diagnostic, 80% of patients are discharged after the non-admitted waiting list. So diagnostics as being a focus on our non-admitted delivery, working on the basis flat cash for next year elective. It's fundamental for transformation. And likely we've got many CDCs. We've got 7 across Sussex, and they're doing by the end of this year about 22% of our total diagnostic activity. But I'm looking at our DMO1 improving, but thinking, are we just churning through patients? How are we not, as a system, collaboratively looking at all of our estates to actually target the waiting times? And lo and behold, for the next 2 months, we'll see a 10% reduction in our DMO1 by working collaboratively, how you target the right pathway. So thinking orthopedics, if everyone has an MRI, and we know that reporting turnaround times are quite challenged in acutes, but 1 week in a CDC, put your challenge specialties through there. And actually what you then do is reduce that lag in the non-admitted. So try and get down to 52 weeks in a different way. So really helpful how you've described that, because it just helps cement why we're doing this, and it's so important. But my question, we've introduced a digital solution, not as successful, called iRefer, which is trying and gatekeep and guide clinicians to refer a patient for the right test the first time. What's your experience in your system in terms of looking at those sort of digital ways of trying to manage demand or put patients in front of the right clinician for the right test first time?
Yeah, so thank you very much. That's I've written down about the work you're doing around directing, and that, again, that might be something that we want to pick up and learn from you, if that's okay. In terms of that kind of gatekeeping and packaging up, we've tried to tackle it by looking at the pathway. Breathlessness being the first pathway, and again, I guess out of scope, agreeing a breathlessness pathway is for the cardiac network. We need to stay in our lane. Our job is to deliver the tests that are within that agreed pathway in a bundled methodology, so that people have a coordinated test, a number of tests rather than 5 different appointments. So step 1 is agree the pathway and then receive that, if you will, and then look for the coordinated pathways that need to be put in place. And what we have been saying is that it can't be just in CDCs, because our capacity is greater than CDCs, and so it might be. So that's part of it. The other thing then is agreeing using the ICE system for the ordering as the gateway, if you will. And iRefer is in place in parts, but the system is less important, if you will. It's gaining that standardized agreement as to the pathway and the bundle of tests, and that's where we've been kind of focusing. And again, it's on our next steps to really motor on that. Some of the guidance that's coming around heart failure and getting the blood test in prior to an echo, we're already, that pathway and that algorithm is in. So moving forward, iRefer is part of that, but it's broader than that, is I think my answer, Daniel.
Thank you, Tracey.
Thanks, Tracey. And Daniel, great question. And also, it sounds like you're doing some fantastic work in your patch, and thank you very much for sharing. And if people are happy to be kind of contacted, where there are points to share, then do pop your details in the chat. Deborah.
Hi, Tracey. Lovely to see you. Just to keep doing my video, because my background's not coming on and off, so I'll just say, one of the things I'd just like to hear your opinion on is, so we've talked about diagnostics and the collaboration in diagnostics. How do you get the wider, broader split? Because we've just heard somebody speaking there about elective. But when other programs are making decisions around outpatients, elective, cancer, UEC even, how do you ensure, what is the collaborative way of ensuring that those programs also ensure that diagnostics is also at the heart of their decision making? Because as you and I know, they might be making something on the left hand, but if it's not considered in the overall diagnostics program, it has a detrimental impact on that overall performance. Does that make sense?
Super helpful question, Deborah. I'm sure Ben will pick up some of the wider points on governance and in the next slot, but Tracey.
Yeah, I was thinking this might be a Ben question as well. So nice to see you, Deb. I think that there's a few things. One is we're being really clear on our plans and what's in our plans, but also seeking stakeholder views as to what do we are an enabler for others, and so what is required of us. So that's one of the questions for the respiratory network or the cardiac network, and the urgent care. programme? What do they need from us? So we are seeking that. And then I think there's the piece of work that we're going through at the moment around the interdependencies between programmes. And it is very much about us being clear on what we will deliver, but also seeking that view. So we, you know, part of our networked and stakeholder management is around, you know, so whilst I'm here, somebody's sitting on the cancer board as we speak to make sure that we've got those interdependencies and also that there is representation. So that diagnostic delivery board that you saw has got a huge wide number of attendees and reps, which then means that we've got stakeholder coverage so that we are not being tripped up, but most importantly, we're not tripping somebody else up. And we've got a PMO approach, which that's part of the piece for every one of those initiatives that I've talked to you about. What's the PID? What are the interdependencies? How do we make sure? And also then how do we then comment on other plans so that it wraps up and make it sound perfect? It's not, but that's the ideal, and in the main it works quite well, I think. And that I think Ben would also talk about the, you know, the conditions that we've got that make that possible.
Thanks, Tracey. That's really helpful, as ever.
Thanks, Deborah. It feels like a perfect segue to bring Ben in at this point. So Ben, as corporate lead for CMAST, is just going to talk us through some of the enablers that have facilitated this fantastic work. So over to you, Ben.
Thanks, Jenny, and good afternoon, colleagues. As Jenny said, Ben Vinter, CMAST corporate lead. There'll be some slides coming up in a moment, I'm sure, but my discussion aims to build on the very real and tangible examples that Tracey's already shared with you, and to share our experiences about collaboration, but also why diagnostics is an absolutely integral part to what CMAST is and what it's about. And as Tracey said, but we make no excuses for saying it again, this for us is about sharing our journey and about why diagnostics is important, but also the challenges and opportunities, but absolutely recognising that we don't think we're done yet, nor do we think we've got it all licked rather. So if I move to the next slide, please. So Cheshire and Merseyside is a big complex system, pretty busy. And we have a mix of urbanisation and some rural areas, and of course our urban areas come with an awful lot of deprivation as well, which can cause some barriers to access, which for diagnostics and some of the timescales associated with that are pretty critical and important. We are one of the bigger ICBs in the country, as Jenny's already said. And with that, one of the bigger collaboratives. We span 9 places. They're coterminous with our 9 local authorities. And for added pleasure, we have a city region mayoralty as well, although at this point they don't have any delegated powers for health. But so it's complex and big, but we think that means that that provides a really good, powerful, wide and broad footprint for collaboration to succeed, focusing on efficiencies and collaboration. But as Tracey said, the important thing about our diagnostics programme is it isn't just focused on the acute and specialist trust, but also covers all of our providers, so mental health, community and primary care also. If we can move to the next slide, please. So who is CMAST? So it started off as 13 trusts. We've had 1 merger, so it's now 12. We have 5 specialist trusts that are regional tertiary centres for our ICB, but also beyond. And we haven't, as a system, always had a strong track record of collaborating, as well as we might like to think that we do, or we're starting to do today. But a really important focal point and foundation, I think, for a lot of our collaboration that's going on our patch at the moment is the pandemic, which may sound a bit like a cliche, but it's true. Through the hospital cell, it set some really key foundations, the starting point for building some of those key relationships, trust, and actually an acceptance and understanding that you only really make progress by starting things and by doing things, and then from that kind of a snowball effect, which then really grounds much of our activity today. So we're doing a number of good things, as say, we don't claim to have all of the answers. We certainly don't think we have a trademark for what collaboration is, but we do think that today, as we sit here now in 2024, last year, we've got a lot of the right ingredients, a lot of the right characteristics, which is really important, and kind of all of those things coming together at the right time. As I said, very much one of our approaches has been about doing and delivering, and from that our programs have formed. So it's still on the last one, sorry, I pick up pace and vary and duck and dive as I go through, but yeah, an important part of our journey really was around, as well as that sort of doing, alongside that, the CEOs and then later the chairs committed quite a lot of time to some OD and really kind of unpacking what collaborative working meant for them, focusing on system design, our collaborative behaviours and approaches, and then you'll see in a little while about how that then links with the diagnostics approach, which is discrete but aligned, and that's a lot of what I think CMAST and Cheshire Merseyside does. It's about the levels and the interconnectedness, but also some commonality whilst allowing local programme flexibility, but then also the spread of that, so bringing colleagues together. We've been very clear that we're building iteratively, and so being keen to avoid like having a perfect model and waiting to establish a perfect model before we started, and actually just more letting the agenda direct our need and being comfortable in each other's company and responding as we've needed to, whilst having a forward plan. So if we could move to the next one now, please. So our priorities, I hope, speak for themselves. They very much do seek at a CMAST level to connect to the wider system agenda, speak to place, speak to our partners, but also hopefully resonate with patients and staff on the front line as well. And just on the next slide is then the diagnostic programme priorities, and hopefully you'll see some commonality there, but again, that individuality, which is important and a part of what CMAST seeks to do, create a net that goes around things, but allows that sort of local response and self-determination, so familial, if you will. On to the next one, please. This, I suppose, is my background. So I'm former director for governance. So this is the bit that excites me, unlike all the important stuff about patient outcomes that probably excites Tracey more and is appropriate and maybe more interesting for some of the audience. But so this is our structure. We're governed by our leadership board, which is CEOs and periodically brings chairs together. It's a serious forum, but it's, I think importantly, it's also focused and very collegiate and supportive as well. And I think getting that mix is really kind of important about how business is conducted. We conduct ourselves on the basis of honesty, trust, and transparency. But then, as you go lower down this chart and to the right, connected to the programs, connected to our professional groups, which ensures there's strong links to each of the individual trusts through all of those professional forums, networks, and clinical leadership, which is all very important to everything that Tracey's referred to already. So move on, please. So thought we'd show you kind of where we built to, and then my next slide is where we are at the moment. But so very much started, as I said, on the doing and your elective recovery and recovery of diagnostic tests, and then as Tracey's alluded to, some of that was filled out and expanded. But bringing on clinical pathways, finance efficiency and value, and workforce. And some of these things are around big programs. Some are about connections and the symbiosis with working in ICS and system working and making sure that trusts are aligned with what the ICS is doing on the money. And really, I think we found that focusing on any one of these as opposed to the whole package doesn't work and wouldn't have worked for us in our patch. So really kind of trying to bring out that interdependence. If I move to the next slide, you'll hopefully notice a slight iteration. Oh, I've got an interesting blob down there on the bottom left-hand corner, which never mind. But an iteration where we brought forward efficiency at scale this year and bringing that out whilst kind of focusing on and being clear about some of the enablers that's supporting what are now quite well-established 4 key programs within CNM. But as I say, very much underpinned by that mutual interdependence. And then I think what hopefully is the last slide from me, and Tracey may wish to come in on some of the questions that this might give rise to, as we put our heads together and sort of brought out the challenges, but also our ingredients for success as we saw them in Cheshire and Merseyside. And I think for diagnostics, one of the things that's really important that I think Tracey did mention is around this programme wasn't started from scratch. It was very much about how you brought together the work, in some cases the successes of existing networks, programmes and structures, and about how we celebrated that, but kind of added some fuel to it and really recognised the benefits of working together. So all of those networks had their purpose reviewed, refreshed, and the alignment to both all of the trust boards, but also what Cheshire and Merseyside, ICS and ICB were doing, and that real connection to that PAN system agenda. We've got kind of, and within that, I think there was an important kind of discussion and realization about some of those established groups had interesting self-perspectives at points in time, felt they were doing the right thing, felt that they knew maybe what needed to be done for the system or the patient, and actually there was an element of holding a mirror up and exploring that genuinely with them, questioning how connected that was to that wider system agenda, trust leadership, and indeed their respective professional disciplines. So clinical leads holding each other to account and building and establishing that culture, which we felt to be very important, but also a shared understanding about the implications, for example, about what a slug of imaging capital might mean for the wider system, a way that money was being managed, which perhaps wasn't always as fully appreciated as we hope it might be today. You've already had Tracey mention, and some of the questions reflected on data and the need to access data in a timely fashion, but also for that to be standardized and understood and readable across the patch. We found that it's very, very important, and not something necessarily cracked, but that supports us in the efficient allocation of our resources, but also drives improvement and standardization, but more to do in that space, but certainly something where energy has been kind of placed to this point. In terms of diagnostic islands, I think Tracey mentioned about the many people that join the diagnostic board, and that's, I think, about the work being progressed, shared, and talked about amongst the company of others, those connections being established, as opposed to it being one particular dominant voice in a provider or another, or a particular professional grouping, and that being a shared understanding and prioritization, which we believe really brings together the full potential of diagnostics. Similarly, we continue to have a challenge whilst we welcome some of the way that capital is allocated. So it's a wonderful thing, isn't it, that diagnostics attracts quite a lot of capital, but that isn't without funding, but that isn't without its problems, and sometimes some of the paces of that can be quite challenging for already hard-pressed clinicians or managers to respond to, but also to understand and best reflect how that can align to system priorities that sometimes take far longer to develop. But we all are servants to the NHS and have to respond as best we can to these agendas, don't we? But I think Tracey and some of the questions also referenced the importance of clinical leadership, and we just wanted to call out that actually doing the day job and the leadership of some of these networks, plus equally some of the issues that all colleagues on this call will be facing the same challenges with in terms of industrial action, but also the need to recover whilst progressing change, whilst seeking to support colleagues with OD is unrelenting at best, and that can't be underestimated. But I think has been approached within CNM in terms of it's better together than alone, and that achieves results, and that colleagues get, I guess, their lift or their adrenaline hit from seeing that improvement. In terms of the ingredients for success, all of our programs, and diagnostics is no different, has a CEO, SRO, and we are very fortunate for our diagnostics program that as we sit here today, happens to be a CEO who, as Tracey said, leads two trusts, our heart specialist hospital in Liverpool, but also our Clatterbridge, our cancer hospital. But Liz is also integrally involved in the work of the Cancer Alliance, and of course all of that interconnectedness helps within that space in terms of the relationships, the appreciation about the need for trust connection, but also the fact that it can't just be acutes or community services doing this alone, but it needs to be connected to place, to local clinicians operating in their local neighbourhood, and that's absolutely key. But similarly, all of our programs have chair sponsorship and that connection to boards. So the fact that we're it's a frequency that's been agreed with them, but that it's not done in secret nor in isolation, nor do we seek to overwhelm them with what's going on, has been important to us as well. In terms of the other things, I think it's what Tracey said throughout, and probably what I've heard on a number of these presentations about provider collaboration. But for us, the leadership, the opportunity to connect and align and build on relationships and trust is just so important. And for us, we find that we're just in a sweet spot at the moment where a lot of the right ingredients are in place within Cheshire and Merseyside, but nor do we think that we've got the only model or manual for delivering that. But I'm not sure whether there's anything else that you wanted to add, Tracey, to what I've said, but I think that's where we thought we'd leave it in terms of opening up to questions from colleagues.
Thank you so much, Ben. That's really helpful to have that kind of the next level up of detail on how you've managed to make all the progress that you've made. I'm just going to ask a question while I give people a chance to think about whether there's other things that you want to ask Ben and Tracey, and do just raise your hand or pop any comments and questions in the chat. I want to just come back on the points around the kind of, we know that trust is so critical. And I just wonder if you had to kind of boil it down, just thinking at board level, when you're kind of pulling together so many different organizations, what's been the thing, in retrospect, that's been the kind of biggest game changer in kind of building that trust at board level across the organization? I mean, I'm sure there's necessarily one thing, but is there, what kind of comes to mind for you as the kind of key things that have really helped get everybody pulling in the same direction?
I think what Tracey may want to come in as well and or to add, but I think for me, we've whilst saying we wanted to deliver and we focused on that and not worried too much about models, at the same time we've been really clear about who as a system we're asking to lead on something and empowering them to do it. And so I think it's about in the case of diagnostics, that's Tracey is the program director and Liz is the sponsor, and it's about then when there are questions or queries, they're being about a validation from that individual, and they're not being 1,000 voices, they're not being I'm CEO of X or Y trust, and they're being an alternative perspective. And so it's about whatever the issue is being talked about, a decision or a direction of travel being agreed, and then that being adhered to collectively, but also when there are legitimate queries, areas of discussion, that being wrapped back into the structure. So again, it's the consistency, I think, of message.
Really helpful. Thanks, Ben. I also wondered whether you could say anything about CMAST relationship with the ICB and any role that they've had in facilitating, perhaps not this particular programme, but perhaps there is a reflection there, but how it supported CMAST work.
Shall I start, Tracey, and then you add? So I think that I think there's a couple of ways. So I mean, I think that they do fund some of our programs of work, and that is an important thing to acknowledge. But equally, we are funded by our membership, and also we get money from national and regional programs as well. Again, I think that comes back to then the clarity point in the agreement. So so CMAST, so Cheshire and Merseyside ICB was one of the later developing ICBs, and I think it's important to acknowledge that, because it meant that when all of the guidance came out about provider collaboration, CMAST had the foundations to build from that I've already referenced, and had an emerging view about what it existed to do. And that meant that when the ICB was in a position to talk to the trusts, that we had a clear understanding about what we thought our offer was, and that was a good meeting and discussion of minds. I think that clarity means that the ICB sees us as a delivery partner and a delivery vehicle for them, and to that extent there isn't a competition, it's not a crowded space, but again it's the single line of sight, the appropriate accountability for delivery and clarity on leadership, and then us being open and transparent as we seek to be with partners, with places, with our members, but also with the ICB. So we're happy to be held to account by them, but equally we have a relationship where I think it's appropriate and collegiate, and it's an inquisitive line of questioning as opposed to traditional performance management, which again works for everyone, I think. But I'm not sure whether the more you'd want to add to that, Tracey.
I think it's a very positive relationship. It's mutually respectful, and I think quick wins builds faith and trust. So we've shown some quick wins, particularly on performance, which shows we will work at pace and deliver, which builds trust. So it's that snowball piece. And so I think what we then have is a respect for the CMAST governance, which allows us to get on and deliver without being accountable in two different directions. It works. And then there's the support and faith and leadership where appropriate from the ICB, such as the lead digital officer from the ICB is chairing our digital group. So we're in the same space rather than mutually supporting each other rather than parent-child. It feels very positive. So I think there's a lot of trust and mutual respect, but only because we've delivered. I think if there was some stuff that we weren't delivering on, that funding wouldn't be coming through, and also that space wouldn't remain in that state, I don't think. So it's two-way.
That's really heartening to hear. I'm going to pull things together because I'm conscious some people may have another call to jump onto at 3. So I wanted to say massive thank you to Ben and Tracey, some really inspiring work that you've been doing, and also just conscious of others, what you've shared in the chat, thinking, Daniel, what's happening in other patches. And it's obviously an area where some really exciting progress being made. And I think in the kind of context of people saying, let's see the examples of what provider collaboration at scale can deliver, I think we've kind of seen some really and listened to some really tangible examples today of the progress that can be made, and how to make the best use of existing capacity as well as adding new capacity. We've looked at some of the key enablers operationally. So I think we touched on things, haven't we, about systems thinking clinicians, how to really get underneath the data on DNAs, digital systems, managing interdependencies with other programs. And then Ben, thank you so much for just kind of underlining some of the key enablers that have really meant that it's felt that it's better together than alone. I think it's really kind of inspiring when staff are under so much pressure that this can be a kind of source of motivation and inspiration when people can see the difference they can make. I'm conscious, Deborah, you just kind of popped.
Yeah, just quickly wanted to mention the fact that in terms of the model that Tracey and company, because I have worked with them, have delivered, I'm in a new patch now. And when we talk about trust, because that's very, very key in a lot of this, I'm winning trust with my executive teams, whether it's ICB or in my local collaborative, by working with Cheshire and Merthy and other systems to bring where they've progressed things very well, and bringing that learning and sharing into a system that hasn't potentially done so well or has a lot of catch up to do. So I just think it's good to point out that whilst Tracey and Ben have talked about their experience in Cheshire and Mersey, that actually their learning and their experiences is also helping other systems. And I think that's really important to mention.
That's fantastic to hear, Deborah. Thank you very much for that shout out. I'm also just clocking, Daniel has said in the chat that it's very happy to share the approach and the work you've been doing in your patch, Daniel, and we'll follow up with you on that one. So just as a kind of wrap up, we've popped in the chat link to our evaluation survey. It only take a minute. We really appreciate your feedback. If you haven't got time to do that, do give us any comments and feedback in the chat. Just a flag, we've got coming up our peer learning forum in February. We have a next webinar in this series on workforce challenges on the 15th of April. And as I flagged at the beginning, we are about to launch the first instalment of a new series on provider collaboratives building capacity, which is going to be focusing on community diagnostic centres and showcasing the work of CMAST in more detail, and also Norfolk and Waveney Acute Hospital Collaborative. So and do just keep an eye out to the range of case studies that Bobby, Katie and our team are working on to just share the benefits of provider collaboration at scale. So thank you very much to all of you. I really appreciate you joining us, and do go onto our website. If you've missed previous webinars, we've got recordings and we've got a whole host of peer learning resources, but thank you very much.